Hello, everyone, and welcome to the third episode of Spread the Tech, a series of the Digital Inclusion Exchange podcast, co-hosted by the National Digital Inclusion Alliance and Digital Charlotte. This series is brought to you through a sponsorship with Verizon to help digital inclusion practitioners adjust to the new challenges brought on by COVID-19. During this episode, Angela Siefer, Executive Director of the National Digital Inclusion Alliance, Bruce Clark, Executive Director of Digital Charlotte, and Andrew Au, Director of Operations for Digital Charlotte, speak with Amy Sheon, the Executive Director of the Urban Health Initiative at Case Western Reserve University School of Medicine in Cleveland, Ohio. Amy is also President and CEO of Public Health Innovators, LLC, an executive board member of the Network of Digital Evidence for Health, and the National Digital Inclusion Alliance's Senior Fellow. During this interview, the host discussed with Amy the intersectionality of health and digital inclusion, with a focus on how digital inclusion practitioners can partner with health providers. We hope you enjoy.
Hello and welcome to the Digital Inclusion Exchange and our special Spread the Tech series in partnership between the National Digital Inclusion Alliance and Digital Charlotte, an initiative of the Knight School of Communication at Queen's University of Charlotte. Our hosts today are Angela Siefer of NDIA, Andrew Au of Digital Charlotte, and I'm Bruce Clark, also with Digital Charlotte.
I'm super excited that our guest today is Amy Sheon. Amy is not only the Executive Director of the Urban Health Initiative at Case Western Reserve University School of Medicine in Cleveland, she is also an NDIA Senior Fellow. Amy recently joined us as a Senior Fellow, even though she's been an evangelist for the connectivity between health and, or it is, right, the connectivity of the connectivity. That doesn't make any sense. The connection between health and connectivity, having internet at home, having a device, having the skills, all of that's impact on your health. So she's been doing that work. So we're excited that she is now representing NDIA in that work. And she's here today to talk to us about that. Amy, let's start with the big picture. Tell us what does that connection look like? Why does it matter to someone's health if they have internet and a device and digital skills?
Thanks, Angela, and thanks so much, Bruce, as well, for having me on the show. It's a great opportunity to make these issues about the connections between health and digital inclusion to raise awareness about them. So for several years, my focus has been on getting people to use the internet so that they could manage their health, like through using patient portals to the electronic health record. But with COVID-19, this has really become a matter of some urgency. People are encouraged to stay home and not to go into the doctor if they have symptoms. So for that, they need the internet to be able to use telehealth. And by staying home, that helps us all in several ways. First of all, if someone's infected, it keeps them out of the public, not exposing other people, keeps them off of mass transit, going into the doctor. It protects other patients who are in waiting rooms getting care for other things. It reduces the exposure of doctors and healthcare providers to that many more infected people, and it saves the scarce personal protective equipment. So it's a help for that individual, and it's a help for all of us in society to have everybody connected.
So, I mean, we know not everyone is connected, and so, thinking about what are you seeing healthcare providers do, especially now, as we were sort of talking before we even came on live, that the local healthcare provider here where we're at said they went from 5% virtual visits to 60+% virtual visits overnight. But we know that is leaving out a percentage of our population who can't access that. Are you seeing any unique activities by health providers to help folks get connected?
So way too few. I've seen way too few efforts by healthcare providers to get connected. I think by and large, a lot of health systems are not aware of how many of their patients are disconnected. And when schools went online overnight, right, schools really had to immediately know which families were and weren't connected, because they're breaking the law if they're delivering school online and not, giving everyone equal opportunity to learn. Healthcare doesn't have a mission or a mandate like that. And so from their perspective, oh my gosh, we're connecting with lots and lots and lots of patients through telehealth. That's great. And they have done an amazing job to make this transformation overnight. But I think that there's not nearly enough awareness of who's being left out and what healthcare is connected.
Mm.
Amy, you've shared with me some of your experiences. You are the person who's interacting in the medical field and with the digital inclusion community. That's what makes you so unique. Can you give us some examples of where you have interacted with the medical community and you were surprised at their assumptions about folks being online?
Yes. I actually give a talk that's something like healthcare's 13 blind spots around the digital divide and digital inclusion. I think that there are several things going on there in healthcare where providers see what looks like everybody and his mother has a smartphone. You look in a waiting room and everybody's looking on a phone, but they don't realize necessarily that those phones don't have the capacity to do everything that would be needed, that people may not have a data plan. Their phone, may not have a lot of functionality, and it may be a shared device. And so for using it for protected communications and all, that's kind of a problem. You don't want to have that, MyChart app on a phone that lots of people can access. They may be using it only over Wi-Fi and in public places. And that's a real security risk, especially for something as private as health data. So, that's one thing that providers just have a blind spot that they're not aware.
So, Amy, we're wondering if you could help us think through what are social determinants of health and why it's important that connectivity be defined as a social determinant of health.
Yay! Thank you. As Angela knows from being on a panel that I convened a couple of years ago at a meeting at the National Academy of Science, the question, should digital skills and connectivity be considered social determinants of health? And one of the panelists, the terrific Chris Gibbons, who was at the FCC Connect to Health Task Force, said digital skills and connectivity are not only a social determinant of health, they are the meta social determinants of health, because without them, you cannot address all the other social needs that arise because of poor social determinants of health. And those, of course, are education, income, employment, finding housing, finding transportation, accessing government services, all those sorts of things. And with COVID-19, has just made that so unbelievably apparent that hopefully we can no longer sweep that under the rug, sort of the way we have for the last decade.
Amy, can you explain to folks why the term, what is the value of the term social determinants of health? How does it impact the activities of a health provider and what they choose to spend money on?
Sure, great question. Wow, and there's a lot in that. So social determinants of health are the kind of things that people like me who have a public health background have been dealing with our whole lives and careers, because we know that health care has relatively little impact on the health outcomes of the population. It only explains about 20%. Social determinants of health are everything else. So in the past couple of years, as the way healthcare gets reimbursed for providing healthcare has changed, healthcare is more and more now incentivized to have people get well, as opposed to just getting paid for delivering more and more healthcare that may not be achieving much. So all of a sudden, healthcare has the financial incentive to address the issues that are preventing people from being healthy. And so there have been a lot of federal initiatives through the Center for Medicare and Medicaid Services that have led to many, many health systems starting to screen all of their patients to find out, do you have gaps do you have insecure housing? Do you have food access? Can you pay your utility bills? And then referring people to address any of those barriers. So I've really, really been advocating for that screening process to incorporate screening around digital skills, equipment, and connectivity.
Okay, Amy, could you explain to us the change in federal regulations around health providers being reimbursed for telehealth services?
Sure. There have been just an earthquake of really, really rapid changes to the legislation. I'll just point out that the overall effect is that virtually any healthcare provider can deliver telehealth to virtually any patient over virtually any technology and get reimbursed for it. And the changes that represent is that previously a doctor had to have a pre-existing relationship with a patient, who had come in for visits before they could start a telehealth encounter. Now, that's not a limit. You can get started right away. Previously, healthcare providers had to be at a healthcare setting to deliver telehealth. Now they can do it from their homes, which if they're quarantined because they've been exposed to COVID, how fantastic that can remain productive if they're feeling well. And the final area that I'll note is that a lot of the HIPAA protections, the health data privacy rules have been eased up so that providers can use their own devices. They can use FaceTime. It's so that however they can communicate with the patient, they should. They're still supposed to be, protecting data privacy, but the government's not going to go after them if they've used these other technologies that don't have those built-in HIPAA protections.
So the telehealth point then, Amy, is that since that is being reimbursed more, then it's more essential for people to have internet at home and the device and the digital skills. And even if they didn't have those things in the home, say the libraries were still open, who wants to talk to your doctor in a public place?
Exactly. But Angela, let me dig into one little piece of what you said, and that is about the reimbursement.
Okay.
So, one of the big changes, of course, is that doctors can get reimbursed for doing a telehealth visit, which was not the case in every state previously, even though it was allowed. Some state Medicaid programs or insurance programs didn't cover it. But in many cases, they get a higher reimbursement if they use a two-way video connection than if they use just audio.
Oh,
and
interesting.
So, yeah. And so and so I've heard many healthcare providers say, well, when we can't, if people can't do a video telehealth visit, we just call them. And that's great. And that's better access for people. But I call that telehealth rather than telehealth because, and I call that second class healthcare because when you think about the richness that a provider has from a two-way video visit, that of course requires much higher bandwidth than just an audio. The provider is seeing the patient's affect, the way a patient can move, sees their physical environment, can do parts of a physical exam, to hone in on a lesion or something like that, can ask a patient to do something that might reveal to the provider the nature of an injury or something like that. The provider can demonstrate treatments, physical activity, this exercise to treat your back pain. The provider can look at the patient's medicine, ask the patient to demonstrate how they take their medicine. So there's so much richness in that two-way video that is not there in just an audio visit.
So Amy, I mean, this is, there's part of me that's excited about this opportunity and, you know, just even sort of personally thinking about taking advantage of some of these features, but I'm also, you know, curious what do you think the likelihood of these changes remaining after post-COVID? I mean, are we going to roll the rug back up and require people to go back in, and or are we in a new reality? And then I think as a second part of that, do we think if we stay with these current changes that would that would incentivize the health providers to be more engaged in the digital inclusion community because of the opportunity that it presents through these new telehealth services?
Yeah, so I would say yes and no and yes and no. And meaning everything I'm hearing says healthcare is never going to be the same again. Prior to COVID, fewer than 10% of people had ever had a telehealth visit. And, you know, I think once people have enjoyed the convenience of not having to leave their house to see the doctor, patients are going to demand it. However, at the same time, we're also hearing that some of the federal legislative changes are very definitely temporary. So I think people need to speak up and advocate for maintaining some of the changes. But we have got to get the health systems on board with looking at disparities in usage of telehealth among their populations. And they should be able to do that because all the information about, you know, what telehealth encounters are happening is automatically captured. They just have to look at it.
Mm.
Amy, NDIA has a broadband research base that you are very familiar with. The link for that is on our homepage, and it has academic and other peer-reviewed research in it. It includes the research that the impact on health by connectivity. Are there particular research points that where you've read and you're like, oh, that's a really good one. Oh, that's a really good one, that you think it's important for folks to understand that research is out there?
Yes. So most of the research that's been done that relates to this is around patients using portals to the electronic health record. And that's really where I became engaged with NDIA and became aware of a small number of superb investigators around the country who have been especially focused on the digital divide in patient use of portals. And that's really where I became aware of this connection, because what was found in Cleveland, Ohio, where I'm from, is that the patients that were not using portals tended to live in neighborhoods where there were fewer people using the internet. And of course, that's related to poverty and education, but it was also related to the fact that high-speed broadband was not made available in the urban core in Cleveland. And as you know, NDIA has repeated that investigation and found that to be the case in many, many other cities. So there's really an access disparity issue that's really a profound matter of social justice.
Hey, Amy, can I ask a follow-up to that? Are you seeing race as a dominant factor?
So race is interesting, and I think it relates more to adoption practices rather than access. So what we know is that it's the areas of high poverty where, and you can speak to this better than I can, where the internet is not as available, that replicates historic economic redlining. So the neighborhoods where banks would not lend money because they were inhabited by Blacks and, as the assessor said, other undesirables like immigrants from undesirable countries. Banks didn't invest there, and I believe NDIA has found there's a lot of similarity where there's digital redlining, that the internet connectivity was not made available. So Poverty, in some ways is a bigger factor. Use of the internet by blacks lacks that of whites, and Hispanics even further. I think, except for cell phone use, that the Hispanic population has had even higher rates of cell phone use than Caucasians. Partly, I believe, connected with having relatives in other countries and wanting to take advantage of being able to speak with people cheaply using digital means.
All right. So, Amy, I have a question from our YouTube live stream. This is actually coming from Dr. Zachary White, one of the professors here at the Knight School of Communication. He asks, what's the best way to communicate the value/need of reaching digitally excluded audiences to healthcare providers? How should we situate this in patient satisfaction language?
Wow, great question. Before we get to patient satisfaction, I think that one of the most impactful things that can be done to get healthcare engaged in the conversation is talking about the data that show connectivity rates in the geographics of the health system. So, for example, we know in Cleveland that overall 21% of households have no internet connection at all. But for low-income households, it's 45% of low-income households have no internet connectivity. And I really get incredulity. People just, kind of don't believe those data. So we need to, kind of layer on multiple sources of data. So that of course, is the first thing. But you mentioned the patient action language, and that's really key because you've got these silos in healthcare, right? The people who are concerned about delivering care, and then the people who are concerned about making sure that those patient satisfaction numbers, surveys, are high, because that affects their reimbursement, their reputation, their quality, and all that. Patients, by and large, tend to love being able to connect digitally with healthcare, although the ones who are resistant to internet use need some encouragement, like, hey, wouldn't you rather just be able to pick a convenient appointment time with a click rather than sitting on hold, for 20 minutes and then going through along with somebody? Wouldn't you rather be able to just look up your own lab result the minute it's available rather than waiting for a call from your doctor? So I think, you've got patients need to be, kind of pointed out what the benefits are for them. But providers also, they have concerns that they're going to get slammed with messages from patients and not get reimbursed for that. And so the health systems have to fit patient digital connect workflow so that you've got someone who's triaging those messages and only bringing the ones that need the provider to the provider. So it kind of together as a system.
That's fascinating, what you're just saying there, thinking about how the system needs to adjust and is sort of forced to do it. I think a lot of folks obviously were planning for these things because they know telehealth is part of the future, but now it's here and in a way that goes, from 5 to 60% visits overnight. So a couple of questions here, and maybe to start with one is, what, are you seeing, there's an element of, do patients know how to access the telehealth services, which to me is more of a basic digital literacy or technology, almost a hardware software conversation. But then there's the other side, which is the making meaning out of it, and the being able to actually change the health outcomes of the patients they serve. And so are you seeing any sort of, maybe more on the rapid response side, in the way that healthcare providers are messaging these telehealth opportunities, thinking about how they're going to have to invest in workshop or training of patients to not just how do I get on portal X, but like, how does being on Portal X help me change my health outcomes? Because that's vastly different than sitting on the table with that sort of doctor there in your face.
Yeah, so I don't see a lot of attention by healthcare to that. I don't really have any good sense of how aware people are of the telehealth opportunities. And I think it's a great opportunity for the digital inclusion community, insofar as they are, getting people connected and training them to use tools. Ask them what they know about digital health. And the digital health community has been trying to, there's a gap in terms of who is teaching patients how to use digital health tools. Health systems aren't doing it because they don't appreciate it as something that needs to be taught. That's one of those blind spots that I talked about in healthcare. Some people in the digital inclusion community have been doing some digital health training, especially, say, libraries. I understand that health is one of the main things that people ask for help with when they were going to libraries, which are such a big part of digital skill training. But let's get those digital skill trainers connected with people from healthcare, so that the digital skill trainers are informed by, what is a portal and how does it actually work, so that, let's have healthcare be able to leverage the great value in the digital skill training, digital inclusion community. I just don't see the kind of partnerships that we've got to have.
No, it's interesting. I am taking some notes here about reaching out to our contacts at the library, thinking about collaborating there on some of those pieces, because we've run some digital health literacy programs in partnership with our local YMCA, and are talking about doing the same with one of our major healthcare providers. So there's the patient side, and sort of follow up to that. How are we seeing doctors and other healthcare practitioners adapt? Because there's the technical component of can I use the portal, but delivering care in a virtual setting is also different, and it's also, there's some cultural competencies, I think, that come across much different when you're looking inside someone's home or inside their car, if they're sitting in their car, wherever they may be. So thoughts on what you're seeing there, and what role digital inclusion practitioners could play in supporting the practitioners themselves.
Sure, and I will just make a little commercial. Pre-COVID, we developed a product funded by Ohio Department of Medicaid that used virtual reality goggles to train providers around the social determinants of health. And so it took them into a segregated, impoverished neighborhood, and followed a 4-generation family to see what are the challenges that people have lead to poor health and challenges in getting healthcare and following healthcare advice. So you're giving me an idea that, boy, it'd be great to do something like that that's very focused on kind of inside a house and helping providers understand what are the clues they should be looking for, how to respond to things that they see. What do you do if you see something that looks like domestic violence, which, I think is something that has happened. So this is a whole new world. I don't think we have a lot of data on how these encounters are going. I would love to see data on just the proportion of telehealth attempts that are successful, and the quality of those in terms of connectivity and dropped calls. I know my 86-year-old mother, who's living in a lockdown independent living facility, was given a set of instructions for a telehealth visit that had, I think, 17 steps that included things, yes, hang your head, right? That included things like, if you can't find the link that we sent you, go to the spam filter and download the software and use this version of this browser, and make these changes to your network.
I just feel the pain as you're saying it, Amy. I'm like, oh no.
Yeah.
Amy, can you talk a little bit about the So knowing that our audience is digital inclusion practitioners, how could they work with health providers? What are the things that they can be pitching to their local health providers?
Great question. So I think the first two things are to make health systems aware of the on-the-ground digital inclusion picture, and maybe what we need to do is develop almost a dashboard or a template report that says this is what the state of digital inclusion in this location, so that providers know that. Coach providers about how to look at their data so that they understand how people are already digitally engaging with the institution. And perhaps most importantly, help providers screen. I mean, I've been working with the digital inclusion community on developing a screening tool with the idea that a health system could administer this routinely to all of their patients and find out their gaps in equipment and skills and connectivity. And then most importantly, develop relationships with the digital inclusion organization to which they should then refer patients to close those gaps. I don't want healthcare to feel like they have to invent this and figure this out themselves. The digital inclusion community has been at this for 20 years, and there is a lot of granular knowledge about networks and suppliers and providers and connecting opportunities that healthcare should not be trying to figure out.
We very much agree.
Yeah. You're just saying some. We had it yesterday with our healthcare provider, and I'm like feverishly taking notes because several of the things you're saying are in line with what we were talking about yesterday, and so I don't really have a follow-up question here, but I'm just thankful for the opportunity to hear from you because it's when we're kind of pioneering, at least in some regards, to have people like you out there who's sharing this information with us here will have an opportunity to listen to this. I think it's particularly valuable and timely, right? So it's like the door opened more rapidly to this conversation, but the door's not closing, I think, as we said. And so, I think this is the plug for all of the healthcare providers across the nation who hear about this and tune in to come to Net Inclusion 2020. Make your plans ahead of time. Sorry, just because I mean that's where these. I mean, you can hear these conversations here. Either live or when you get a chance to listen to this, and but to the point that Amy made, it's that like trust building, the community building that they have when we had 3 calls so far with, just as an example, 3 calls so far with the healthcare provider. And the first call and the second call, there's this getting to know each other. And the third call was so dynamic because there was like, okay, I understand your intentions. I understand your skills. And we started to open up and begin to make real plans to think about what this looked like. And one of the funny things that happened was between the second and the third call, such a large healthcare organization that the conversation that we had with them had sparked some ideas, and they went back and uncovered resources that were within this huge healthcare system that they hadn't yet identified, and not for any reason other than it's just a lot going on right now. And when it's 5%, it's one thing. Percent of your patients are on telehealth visits. You have to come at it
right. And if you think about what's happened in the education sector, right, overnight, schools have had to partner with the organizations that are able to procure thousands and thousands of devices. They may be refurbished, they may be low cost, they may be free, to get those configured and out to students. Healthcare should be doing the same thing. And amazingly, there's still probably $160 million left in the Federal Communications Commission's COVID-19 telehealth funding program, where healthcare institutions can apply to actually purchase devices and data plans for patients to support telehealth. Now, that is an unbelievable opportunity because so much of the funding that's been out there would not cover end user,
That's
the
right.
patient's device and data plans. And so I've been trying to counsel some healthcare systems on how to go after those funds and how they can find people to partner with to provide those devices in bulk. So there's still money out there. Unfortunately, that funding opportunity does not come with any resources for technical support or for staff. And I really wish, and so maybe health systems, knowing that they're going to get so much more revenue when their patients are connecting by video rather than audio. I think they get reimbursed triple the rate. That, well, wow, maybe that would pay for them. Bring in some of those digital inclusion
Right.
experts to help get their patients connected.
Let alone the percentage of people that are now not even doing the telehealth visit. I mean, that was part of it as well. As they can only do the telehealth visit, but they have a percentage of people that aren't connecting. So you have the video or the audio, the video, but then you have the patients who are doing neither or neither, who then could potentially connect. Could you say that one more time? That where that fund is, or what?
Sure.
Could you say that part one more time?
Yes,
Sorry.
It's the Federal Communications Commission's COVID-19 telehealth funding. One other thing I want to throw out there is an opportunity to use community health workers in this workforce. And again, that's something we've been developing in Cleveland. Community health workers only have to have a high school degree. And in Ohio, they go through 100 hours of training at a program that's been certified by the State Board of Nursing. They have 130 hours of clinical practice. What I've been advocating is let's train those community health workers to be digital skill and connectivity assessors, have them do the screening and referral to the local organizations that get somebody equipped and get them basic digital skill training. And then once a patient has that, a community health worker could be the perfect person to then help the patient, first of all, understand what is the value of, say, using the portal and digital tools, and maybe even providing the basics of tech support for getting connected for a telehealth visit. So some health systems and insurance plans have been hiring community health workers, but I think this is a big opportunity that hasn't yet been fully exploited.
Regarding the funding from the FCC, NDIA held a webinar with Ice Miller, a law firm in Columbus, Ohio, that has been helping their clients apply for those funds. So that webinar was recorded. If folks want access to that webinar, ask Caitlin or myself, and we'll get you that recording. So Amy, we're at time. We so appreciate you being here with us. Is there anything that we should have been discussing with you that we missed?
I would say the one thing is, that the federal government is recommending that tracers be stood up to contact everybody who's been exposed, find out who, they've exposed. And that effort must also involve to quarantine safely. And I think that making sure somebody is digitally connected should be number one on the list of what they do. If that person is not connected, can they safely quarantine? Right. So, those contact tracers, let's hire community health workers, get them trained to do the digital assessment and connectivity.
That's a fabulous point. Thank you, Amy.
Yeah.
Thank you. I appreciate the opportunity to about my favorite subject.
Well, thank you for joining the Digital Inclusion Exchange and our special Spread the Tech series. It's a partnership between the National Digital Inclusion Alliance and Digital Charlotte, an initiative of the Knight School of Communication at Queen's University of Charlotte. Thanks for joining us.
Thank you.
Bye, everyone.
Bye-bye.